Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host for today's webinar. Today, Dr. Dorothy K.Y will present bright light therapy for mood disorders, including bipolar depression. The Brain and Behavior Research Foundation funds the most innovative ideas in neuroscience and psychiatry to better understand the causes and develop new ways to treat brain and behavior disorders. These disorders include addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, OCD, post-traumatic stress, and schizophrenia. Since 1987, the Foundation has awarded more than $394 million to fund more than 5,700 grants to more than 4,700 scientists around the world. 100% of all donor contributions for research are invested in our grants to scientists. I'm delighted to introduce Dr. Dorothy K.Y. Dr. K.Y. is an associate professor of psychiatry and behavioral sciences at Northwestern University's Feinberg School of Medicine. She was a 2002 and 2013 Foundation Young Investigator grantee. Today's webinar will begin with Dr. K.Y.'s presentation. This will be followed by a question and answer period. To submit your questions, please use the Questions tab on the control panel of your screen. Feel free to submit your questions throughout the presentation, and I'll present as many of your questions as time will allow when the presentation has been completed. And now, I'm pleased to introduce Dr. K.Y. Dorothy, the floor is yours.
Thank you, Dr. Borenstein. I'm so grateful for the opportunity to speak with you and listeners and to discuss some of the interesting findings regarding light therapy for mood disorders, especially how it pertains to bipolar depression. And I'm going to show my screen. Please let me know if there's any problems.
It's just perfect. Thank you.
Great. Okay. So the bright light therapy is such a comprehensive topic, and I'm going to try my best to focus it on mood disorders. Today we're going to go through what exactly is bright light therapy, clinical indications, some of the possible mechanisms that underlie bright light therapy, how to implement it based on our clinical trial findings. So this is using our research from clinical trials data to inform how we practice light therapy treatments. Specifics on dosing, how to determine efficacy, adverse effects, and how to monitor for safety. And also of great importance is discussions on where this research will lead us to and ideas for new research studies. So hopefully we'll have time for everything. Really appreciate the questions that were submitted, and I will try to answer many of them during the talk, if not afterwards. So bipolar disorder is a major mood disorder and of high concern for public health authorities. The prevalence is high. It can affect 1 to 2% of the population, and patients who have bipolar spectrum may range from 3 to 6% of the population. Patients often experience major depressive episodes more so and more often than manic or hypomanic episodes. It's linked with increased suicide risk, increased frequency of other disorders including anxiety, alcohol and substance use, impulse control and eating problems, and also with medical disorders. The treatment options for bipolar depression especially is still very limited, and I present the low rates of response, even with the existing treatments that was studied, mood stabilizers and with antidepressant therapy. And here's a slide that describes what exactly is a manic episode. The newer DSM-5 diagnostic criteria tries to provide an emphasis on not only patients who have bouts of elation, euphoria, and expansive mood, irritability, but also combined with agitation, increased energy. Patients who have mania can present with strong and intense symptoms linked with functional impairment for at least a week or more. With hypomania, it might be a little bit shorter in duration, and patients may actually still be quite functional when they have the hypomanic episodes. So So just go to the next slide. But major depression is a real problem with bipolar depression. And the patients who experience major depression and bipolar disorder, major depressive episodes and bipolar disorder, often describe what we call atypical symptoms. So with the low mood, with the anhedonia and diminished interest characterizing major depression, they also have problems with increased appetite, weight gain, oftentimes sleep disturbance that's described as hypersomnia, increased or excessive need for sleep, daytime napping, psychomotor slowing, low energy, fatigue, leaden paralysis, along with the other characteristic symptoms, including feelings of worthlessness, excessive guilt, poor focus and concentration. And with severe forms of depression, patients have suicidal thoughts, thoughts of death, may even plan or attempt suicide. So what is exactly bright light therapy? So bright light therapy involves the daily use of a bright light box that you can see featured here at home or in the office. And the indications have been developed based on years, almost 3 decades of clinical trial studies to confirm the efficacy for such disorders that include seasonal affective disorder, non-seasonal depression, phase-delayed sleep disorder where patients go to bed super late and wake up at midday, and also intriguingly possibly for perinatal depression. Bright light provides a rapid and robust response, and if it's effective, it will be sustained if patients continue to use the light therapy. For seasonal affective disorder, the onset of action is as quick as 4 days or even less. The mechanism is attributed to the circadian phase resetting effects of time bright light in the morning. We'll go into that a little bit later. So why should we consider light therapy for patients who have bipolar disorder and bipolar depression? Well, it certainly may, some of the effects may relate back to the ability of bright light in the morning to regulate circadian rhythms, improve their sleep and energy, increase alertness levels, and alleviate seasonal mood symptoms that tend to onset in the fall and the winter, and typically spontaneous resolve in the spring and summer. With bright light, we don't see many intolerable or adverse side effects. Light dose can be titrated against the emergence of side effects, so we can increase or decrease the duration of the light depending on whether side effects are present. We can use light and avoid the problems with drug-drug interactions with many of our disorders and treatments that we offer. The treatment is affordable. We can go into that a little bit later. I can't discuss much now. And like I said, there have actually been studies that have shown that atypical symptoms, patients who have these atypical features of depression, may be a positive responder to light therapy. In light therapy, from decades of research, we are sort of coming up with more confirmatory data that suggests that patients who have a certain type of depression, whether it's seasonal or non-seasonal, there are some patients who experience depression that is related to circadian phase delay. So what happens is that patients with a phase shift related depression has a mismatch in their sleep and their wake patterns, or their sleep and wake cycles, with their internal circadian pacemaker that's regulated by the brain, the suprachiasmatic nuclei. And by resetting their circadian phase and regulating it using forms of treatment that include bright light in the morning or psychotherapy that is designed to regulate social rhythms, we may be able to restore this or correct this mismatch. And as a result, use light to move the sleep timing a little bit earlier, and sort of move people activity levels and behaviors a little bit earlier during the day, and that by doing so, we can realign, restore synchrony with the internal endogenous circadian rhythm. Doing this should improve sleep rhythm, sleep quality, depression, and energy levels. So there's one potential explanation for why the light therapy might be effective. and this is a slide that sort of goes over in a little bit more detail the prevalence and the age of onset of seasonal affective disorder. And its seasonal affective disorder and seasonal patterns can be found in patients who have major depressive disorder, bipolar disorder, and is characterized by a regular temporal pattern in the onset, intensity, and remission of symptoms. So with winter depression, typically onsets in the fall or winter and spontaneously remits in the spring. To be strict in the diagnosis, the DSM-5 requires that patients have 2 seasonal episodes and no non-seasonal episodes for 2 consecutive years. So that's the strictest definition. Intriguingly, some patients who have SAD and bipolar also experience summer onset hypomania, and this can affect up to 2 to 8% of people. As you can see here, whether we use proper diagnostic interviews or whether we use self-reports, we are detecting rates of syndromal and subsyndromal that may be a little bit higher than we would expect, and increased prevalence in the young folks, which I highlight in the red circle. So light therapy for seasonal affective disorder, as said earlier, we have 30 years of research on this topic. It started out with units that produce low levels of light, and patients were asked to use it for a good number of hours per day. Initially, they were tested 2,500 lux was probably the max amount of light that could be produced and emitted from the light boxes in 1989. They were used for 2 hours per day. Within a period of a week time, they were finding significant remission rates in the morning that were much greater in the morning compared to using the light in the evening or at midday, and significantly more effective than placebo units. Then in '98, researchers had the access to more advanced lights, tested 6,000 lux of light therapy used for 1.5 hours a day for a period of 3 weeks, testing against a very innovative placebo unit that sort of allowed the expectations of response to be equivalent among patients who were given the active unit versus the non-active unit, and again found significant effects within 3 weeks with the use of bright light in the morning compared to the non-active. But some of the earlier trials were powered properly, and they did have sufficient sample size to prove an effect, but many of the earlier trials were still limited by having small numbers in their groups, and sometimes they were combining patients at unipolar and bipolar patients at once. Intriguing study on timing light therapy for winter depression, and with use of a sort of more intense light box for a briefer period of time, the 10,000 lux light therapy for 30 minutes per day for 2 weeks, they actually found that morning versus evening light can produce some response. The robust response was seen with morning light, some responders to evening light, but what is intriguing is the last point, that they actually found the patients who started with evening light, then transitioned to morning light, were able to gain more response than either of the 2 groups above. I'm not really sure what's going on there, and I think we may still need to do more research on that area. Building on these intriguing and promising and compelling studies, the group from Canada then wanted to find out, well, can we in fact compare the effects of light therapy against medication? And at that time, fluoxetine was very accessible, found to be effective for major depression and also for seasonal affective. And this group actually conducted an 8-week clinical trial and designed, again, an innovative study design where they combined light therapy with a placebo pill versus another group where they used antidepressant and a placebo light box, and intriguingly found that the remission rates in both groups who used light therapy for 30 minutes per day between 7 and 8 in the morning, which is at the time of awakening, and the remission rates were pretty much equivalent, 50% and 54% in either group. However, light therapy induced a faster response, similar to what the earlier studies found. So by week 1, patients were already responders and heading towards remission. Whereas with fluoxetine, it induced more side effects, agitation, sleep disturbance, palpitations, and these are very common side effects often reported by the patients who I see in clinic. So for patients who are struggling with side effects, seeking a non-drug option, it may be a really feasible and appropriate solution to help with their seasonal symptoms. Onward to non-seasonal depression. With non-seasonal depression, same group, years later, and thinking about how difficult it is to do light therapy clinical trials, we won't go into this today. But really the challenge is enormous, and to be able to conduct is just a major feat. In non-seasonal depression, 8-week clinical trial, they compared 4 groups of patients who were randomized. It was a double-blind, placebo-controlled randomized trial. They compared groups that received bright light, 10,000 lux standard, plus fluoxetine, which is sort of a combined treatment option, light therapy plus a placebo pill, light therapy on its own, which is light therapy on its own, fluoxetine plus a non-active light unit, and then placebo pill plus a placebo light unit. Intriguingly found that the most robust response was actually seen in the groups that were randomly assigned to the bright light. So whether it was bright light on its own or bright light with a low-dose fluoxetine, produced significantly larger effects compared to fluoxetine on its own or even the placebo. So the other interesting take-home message here is that the light therapy actually induced response that took a little bit more time. The effects that differed from the placebo effects separated out at week 4. So remember, back at the seasonal depression, the separation effect was actually as early as a week 1 and the onset of action as early as 4 days. Here we see a more delayed, more gradual response. And there's more that we can talk about that, and it may actually speak more to the mechanism of action or mechanism of effect of light that we still don't completely understand, but we can discuss the possibilities later. So really, response and remission are separating out between the active light versus the placebo at week 4, week 6, and week 8. Next, I wanted to go over what are the findings with light therapy in perinatal or antepartum depression. Now, there are good reasons why we might want to consider treating antepartum or perinatal depression with bright light. First of all, depression in pregnancy is a major concern. It is highly prevalent. It can affect 14.5% of women actually experience a new episode of major or minor depression during pregnancy. Postpartum depression, which onsets within the first 3 months after birth, also occurs at rates of 14.5%. And the symptoms of depression and anxiety often intermix and may relate to the physiological dysregulation from pregnancy or from postpartum. Oftentimes when patients have depression in pregnancy, it can affect their appetite, their nutritional intake, and both of which, having problems with underweight or overweight obesity, can relate to adverse outcomes, as well as just having ongoing stress, ongoing symptoms of depression and anxiety that are untreated can relate to increased risk for adverse effects, including preterm birth. So for that reason, we are truly motivated to find effective treatments for depression and pregnancy. Can also result in untreated symptoms can also result in cognitive changes, effects on safety, being able to care for mothers, being able to care for themselves during pregnancy, and also for the mother babies after they're born. Untreated maternal depression is related to increased use of alcohol, drugs, and smoking. Certainly can impact interpersonal relationships and financial well-being, and just the overall capacity to provide the attachment that the babies need after delivery. So we're really motivated to find effective options for antepartum depression. Morning light might provide a very promising option. So colleagues from our group and others, my mentors listed here below in this slide, together they created this very innovative study design. They looked at patients at baseline, and then they looked at patients presented with light therapy. Then they examined what happens in the withdrawal period after removing the treatment. At baseline, without light therapy, patients had moderate to severe depression, as you can tell from the symptom scores. With the treatment, they provided 60 minutes per day of 10,000 lux light, had patients use the light therapy within 10 minutes of awakening for a period of 3 to 5 weeks. And the results were intriguing. Within 3 weeks, patients were experiencing response. 50% were responders by the 3-week time point, and in fact, 4 of 7 developed remission by week 5. They did not find any adverse outcomes. There was a very careful characterization of the outcomes of the babies and the moms. The majority of them were able to deliver at full term. Let's see, I think they had one mom who did deliver a little bit early, quite a bit early at 30 weeks. Another baby was born at 32 weeks. The others were born at full term. The APGAR scores were very good. The APGAR scores at delivery were 8 among the babies who did provide data. And all 15 of the children reported to have normal weight gain, growth, and attainment of milestones in the long-term follow-up. No significant safety issues emerged. And this, coming from this study on antepartum depression, they found some really unique findings, that the onset of response in perinatal patients was a little bit slower, in fact, a lot slower compared to SAD patients. And it really did take 5 weeks to onset. By withdrawing the light therapy, patients actually experienced a recurrence. As you can tell, the mood scores dramatically increased even within a week of withdrawal. So it really speaks to how quick enduring the effect can be, and also how quick the effect can reverse by stopping the treatment. And I'm just going to move over to the next slide. This is just a quick slide to characterize. In another follow-up study, they found that dose manipulations can be very effective. And in fact, one of their study patients developed transient hypomania on the full dose of light and needed to reduce the duration of light from 60 minutes to 50 minutes in order to gain the full response and get rid of the hypomania. Others actually needed to exceed the 60 minutes, and partial responders at 60 minutes actually became full responders by actually increasing to 75 minutes per day. So because of all the promising data, the perinatal light group went ahead and eventually were able to set up a study, again, a gold standard randomized placebo-controlled clinical trial, and use light therapy to test light therapy for antidepressant using placebo comparator. And intriguingly, developed a 5-week study, but when you look at the responders and remitters, clearly remission was still ongoing. If you look at the week 5 time point, remission still is heading in this direction. So if we had time to extend the study beyond 5 weeks, you may actually see a larger proportion of remitters. But if we looked at the endpoint analysis on completers versus what we call intent to treat, which is all of randomized patients, we will see differences in the rates of response and remission. And there are good, there are reasons to argue looking at the data based on completers versus all randomized patients. On completers, we are sort of self-selecting for a very potentially very motivated group who are perhaps more likely to respond. The intent to treat analysis actually may be a bonus for clinicians because it actually allows us to understand a more generalized population or generalized sample where we actually have patients who don't necessarily continue treatment. And even if we do look at all of randomized patients, the rates of response and remission are quite considerable and very reasonable compared to antidepressant therapy. And we find remission sort of response rates of 54% using the HAM-D17, remission rates of 45.8% with bright light. So remission and response rates are very similar, 45% and 54% after a 5-week trial of bright light compared to remission rates with the dim red light placebo of 18 to 22%. So these are compelling data that suggests that light therapy can be very effective for antepartum depression. So in our group really focused on developing treatment options for women with major mood disorders. And for this reason, in addition to studying the perinatal patients, we were intrigued to find efficacious treatments for women with depression. And that led to our earlier trial from years ago, where we conducted a preliminary dose finding safety and efficacy trial. We implemented a 7,000 bright light treatment in an 8-week study, and we actually in this, though it's a case series, we implemented a placebo exposure at the beginning of the trial, so that we can compare response to some form of a placebo exposure compared to the active treatment. So patients were blinded to the study design, were not told what to expect. The evaluators and the clinical clinicians who evaluated were also blind to the study protocol, so they did not know what the patients were receiving or where they were in the study visit. And we implemented 2 weeks of bright light after the 2 weeks of placebo lead-in, starting with 15 minutes a day. And we followed the SAD protocol, which is implementing morning light, used in SID, used in some studies for non-seasonal depression, incrementally increased the light therapy exposure by 15 minutes every 2 weeks, a maximum of 45 minutes per day. And we expected to see an onset of response within the first 2 weeks, and we did with the first patient. However, after running 4 patients with morning light, we found one full responder, and in fact, we actually, frighteningly detected 3 who experienced mixed symptoms and hypomanic induction or manic induction from the use of bright light in the morning. Let me just go to the next slide. And this was a really profound effect. We were, I think I was one of the blinded raters, blinded physician working alongside with the blinded clinical raters, really became a little bit concerned and perturbed with the this manic induction and how quickly this was happening with the morning light therapy exposure. And here we display panels describing the exposure, what was going on with the exposure to dim red light, and then as patients moved along, the experience of exposure to the morning bright light. And quickly, within the first 2 weeks, we were observing the induction of mania mixed symptoms. So we did have the gold star patient who did experience morning light therapy and a nice, smooth, persistent response throughout the 8 weeks. And because of this observation, we certainly could not continue to run patients, in this morning light protocol, given that we're inducing the mania mixed symptoms. And so we actually needed to put the trial on hold and form the institutional review board and our data safety monitoring board what was going on. And then we took a look back at the literature, consulted with our colleagues who are light therapy experts around the world. In our literature search and also in preparation for this study, we did recall that there were some groups that were looking, there was one group who were looking at the outcomes of time light therapy, comparing morning light to midday to evening light in bipolar patients who actually had rapid cycling mood disorder, because at that time in the mid-90s, rapid cycling mood disorder was a really hard disorder to treat, and eager to find any kind of benefit patient. The researchers were looking at novel treatments that included bright light and timed use of light. And in their pilot data report, they suggested that midday light may provide a more smooth response and a beneficial effect that outweighed the effects of evening light. And they too described some increased agitation, irritability, mood swings that in the morning light group that demanded cessation of treatment, even in their small pilot study. So likewise, basing our based on what we found in the literature, we revised the light therapy protocol and implemented a midday light therapy protocol, carefully introducing the light at midday between noon and 2:30 for the same following the same careful dose titration protocol. In fact, we may have started patients rather than at 15 minutes more at 7.5 minutes per day, increasing the light dose every 1 to 2 weeks by an increment of 7 to 15 minutes per day. And again, intriguingly, we're able to ramp up the dose across the 6 to 8 week protocol to the target of 45 to 60 minutes per day, and found that 3 of the 5 patients assigned to midday light became full responders. One patient who experienced partial response to midday light intriguingly became a full responder when we moved her the timing of her light therapy to the morning. And this is not, this is sort of alluding back to some of the earlier research where patients were asked to transition from evening light to morning light. Here we're asking patients to transition from midday to morning light, and they were actually able to gain a full response. So it may speak to sort of the effects of midday light to ignite some of the antidepressant effect, but some patients actually may need a morning exposure to really experience a robust effect. The important piece to this is that we needed to implement standard sort of screening for hypomania and manic symptoms, not always done routinely, but probably if we're going to be treating patients who have bipolar disorder, or even patients who have depression, that knowing that there is a considerable percentage of patients who have unrecognized bipolar disorder, we may be needing to implement careful routine screening in our research studies, but also in clinical practice for the emergence of hypomania and mania. We did not find emergence of suicidal ideation. We can talk about that a little bit later. So because of the promising findings from our earlier work, we were compelled to move forward and really confirm the promising effects and find efficacy treatment effects against a placebo comparator, and again in a randomized placebo-controlled clinical trial. And in this trial, we modeled it on the original study using 7,000 lux of bright light against dim red light 50 lux. At midday, we used the same titration curve, assessed carefully for mood symptoms, and also for side effects, for suicidal ideation, for functioning, because patients who improve in their mood symptoms without regaining good functioning, we really need to sort of question whether or not this is a sufficient treatment for patients. The scope of the study was tremendous and much, required a lot of effort. We screened a high number of patients by phone, consented 93, were able to randomize 46, and had 23 in each group. We had some withdrawals in both groups, a little bit more in the inactive group. Many of the patients who were excluded from the randomized control trial were excluded because they would have been a safety risk if we kept them in the study. So these are patients who have rapid cycling, who had some hypomania, who had a little bit of psychosis, who were in the midst of adjusting their treatments. We could not bring them into the study. If they had a positive EDS, we were not able to bring them into the study. So what did we find? So we designed this trial. We conducted the trial for a period of 6 weeks. The patients who were randomized to the active light versus the inactive light were assigned to the exact same treatment or titration protocol. We assessed them more frequently. We assessed them on a weekly basis, either by phone or in the office. And what did we find? Well, this is what we discovered. Now, in the process of looking at the data, we realized, there are some factors that can actually impact the outcome that was unrelated to the light exposure. So things like how old the patient was, the time of year of exposure, the baseline mood scores and functioning levels. If there was any differences in baseline, we actually did not. We had to correct for any differences. We did not. So what we did find was after we compared the remission rates, the mood scores, the response rates, the functionality at each time point. And what we did find was that the remission gain by being randomized to the bright white light was significantly greater than the remission experienced by the patients who were randomized to the dim red light. The remission rate with the active light was 68% compared to the non-active dim red light was 22%. The mood scores were also significantly different. So at the time of the final visit, what we found was that patients had pretty much minimal to no active symptoms of depression in the active group, and we're still having mild to moderate symptoms in the non-active group. And again, the effects were significantly different between both groups, and the functionality was also much improved in the patients who received active bright white light compared to the dim comparator. So what we have here is that we have a promising treatment that involves using adjunctive bright light. I forgot to mention this, I'm sorry. But what we required patients to do is, with the bipolar disorder, all the patients needed to be on a mood stabilizer. They needed to be on a stable dose of an indicated mood stabilizing agent for a period of 4 weeks in order to be enrolled in the study. The patients were also allowed to continue treatment that was long-standing in existence. So if they were receiving ongoing psychotherapy that was unchanged, they were permitted to enter the study. If they're also on antidepressant treatment for a period of 8 weeks or more, they too were also allowed into the study. So this is a treatment that involves light therapy, but it's really an adjunctive treatment for bipolar disorder. It cannot be used as a standalone treatment. Otherwise, we would be very concerned about inducing mania. So that's one important thing that I want to make sure that we emphasize here, that this is adjunctive bright light used at midday and with the presence of existing mood stabilizer therapy. So again, in both groups, at week 0 and week 6, we did not find significant differences in what patients were expecting from the light before and after they were in randomized to treatment. So in summary, what do the findings suggest, and what do they really mean? What we find here is that midday bright light is a potent and stable antidepressant compared to placebo. We find significantly higher rates of remission, lower depression scores, better functioning, and patients are protected from mood polarity switch with the use of midday light in combination with a mood stabilizer. Intriguingly, the dose titration protocol, we wonder if it might have mitigated some of the risk for emergent mania, in addition to the use of midday light anti-manic therapy. But we still needed to have patients reach that full sort of 60-minute per day target dose in order to gain effect, since we were able to detect remission rates only at week 4 to 6 weeks. So week 4 and afterwards is really a time point. We compare what happened with our colleagues who tested morning light versus a different type of placebo unit for a period of 8 weeks, and they found that there were actually considerable changes in mood. In fact, both groups who in this study that was published before ours, where they tested morning light against the low-density negative ionizer, found that morning light and low-density ionizers provided some antidepressant effect, almost, I think, 50% response rates in both groups. And so we wonder if the robustness in the response might have been attributed to, in fact, having a comparator that might have been providing some type of effect. But we would sort of need to do more research into why morning versus midday might provide response that is different, sort of in different clinical trials. The other intriguing point to the study by Dauphinus et al., where they tested morning light, is that they actually provided a 4-week stabilization phase, and it's quite possible that added phase may have provided sort of more response than expected and sort of diminished the antidepressant effects that would have been detected had they not started the morning light right off the bat. So I wanted to go through, in summary, just wanted to go through some of the clinical suggestions on how to use light in clinic, and also from building on that, some of the new research findings. So given the clinical trials data, I just want to go over a few slides that are of more clinical relevance before we talk about ideas for new research building on what we did find. So ideally, we would suggest that patients select a broad spectrum white light that provides emissions of 7 to 10,000 lux, UV filtered white light, with it's equipped with a diffusion screen to minimize glare. And what this means is when you look at the light, it's sort of a more diffuse light. You don't see the bulbs inside sort of like protruding from the unit. 12 to 14 inches in distance, but no farther than that, to ensure that there's adequate exposure to the face. Place the light box at eye level, downward tilting. Eyes need to remain open. We ask people not to stare directly at it, or they will quickly cause fatigue. The parameters for seasonal affective, non-seasonal depression are very similar. Start with 30 minutes a day at awakening. If patients get only a partial response, they can increase to 45 to 60 minutes a day. If people are required to sit for longer sessions, they can stretch and take a break for a few minutes and come back. Clearly, adjunctive SSRIs may be very effective, especially for non-seasonal depression. And the time to response to remission is a very important point of discussion for our patients. To allow patients to understand what to expect will probably help to promote their adherence to treatment. And so with SAD, patients can experience a quick response, whereas for non-seasonal, people really need to persist and may need to wait 4 to 7 weeks. For perinatal depression, at least 5 weeks. And to help optimize the response, sometimes we may actually sort of go back and try to characterize what their circadian rhythm and systems are like by having patients establish what their clinical chronotype is. Filling out a questionnaire like the Morningness, Eveningness questionnaire will allow us to sort of predict where their circadian rhythm is, and by doing so, estimate their the MEQ will provide sort of a little bit of estimation on when the evening melatonin is released that's linked with their circadian rhythm system. And I would suggest, it's a little bit more in-depth, going to the website cet.org, which is Center for Environmental Therapeutics.org. There they will provide you with an automated MEQ questionnaire, and not only that, they'll spit out the time of optimal light use that may be linked to your clinical chronotype, so we can sort of have people try that out. Parameters for adjunctive light for bipolar depression. Definitely patients need to be on a mood stabilizer. Forgot to include that in the slide, but they must be on a mood stabilizer that's on a stable dose. They can start with the 7,000 lux blue enriched white light box for a lower duration of 15 minutes per day at midday. Add 15 minutes each week and target for 45 minutes per day. With both using the light therapy for seasonal affective, non-seasonal for bipolar depression, really important to have a clinician provide education on the response and monitor for outcomes, which can include the antidepressant effect, but also adverse effects, suicidal ideation, and mood polarity switch. Really not a good idea to try to undertake light therapy on an individual basis without any clinical monitoring. So with the midday light, we'd suggest that patients who are partial responders, given the experience with our earlier clinical trials, some patients judiciously may move their timing of midday light to morning if they're only getting a partial response, to understand that it may take 4 to 6 weeks to onset and remit, and important to discuss treatment adherence and really help people visualize how they incorporate light into their daily schedule. Side effects are important to inform patients about, and they include agitation, irritability, headache, eye strain, nausea, insomnia, and rarely risk for hypomania and mood polarity switch. Strategies to limit the side effects, we already talked about a little bit. Sometimes if they're really intense and strong, patients may need to reduce the dose, even stop and re-challenge after a few days of rest. Start back at a lower dose, increase by smaller increments, but still it will be likely important to aim for the target dose to achieve a full response. Okay. Safety data. So really the safety data done recently and also years ago have suggested there's no evidence of ocular adverse effects, no evidence of retinal toxicity with the use of broad spectrum light treatment, which means that it's been UV filtered. The data were based on 5-year follow-up studies. Avoid the use of full spectrum lights because it can produce harmful ultraviolet rays and can cause retinal and skin damage. And really express caution with the blue light hazard because the blue light may be linked with photochemical injury of the retina, age-related macular degeneration. We don't have any safety data on the extended use or exposure to narrow bandwidth, so blue light that's produced in the 400 to 500 nanometer wavelength. So we really need to understand the promising, exciting publications of using blue light for any clinical condition needs to be tempered with understanding of the safety data, for which we still don't have sufficient. As we said, really important to assess for response on a regular basis for any kind of emergent suicidal ideation, mixed symptoms, worsening symptoms for which we may, need to maneuver from light therapy to other treatment options that are more aggressive, whether it's TMS, shock therapy, other forms of treatment that are a little bit more robust. Important to explore for any resistance to treatment by understanding, the use of alcohol and substances and whether there's any relapse. And contraindications, really no real contraindications to the use of light therapy. There's some medical disorders that can worsen with sun and photo exposure, and which are listed here. Increased photosensitivity from certain medications, including antidepressants and antipsychotics that we prescribe. We have to be ultra careful with the medication we prescribe. Likely the use of bright light therapy will not provoke a photosensitizing effect, but we don't know, so we can caution patients on it. More so, it will result from the exposure to sunlight, bright sunlight or any kind of sunlight, so we need to be careful about that. So eye safety checklist, and this is really interesting. So in conducting some of the early novel, at that time, novel protocols, we were mandated by the IRB to implement an extensive safety check for not just physical and mood symptoms, but also for eye safety. So we did that. We used the Columbia Eye Exam that was developed by Dr. Turman et al. And carefully screened for any possible photosensitizing effects or diseases before patients were allowed to enter in the study. And as part of the eye safety exam, we worked with ophthalmologists at the University of Pittsburgh, and our colleagues included Dr. Jake Evan Waxman, who is an ophthalmologist and scientist and residency director, and also with our electrophysiologist, Valeria Fu, to carefully characterize the safety of our patients before they were enrolled in the early light therapy trial with women only. And so we implemented eye exams to check for acuity, to check for contrast sensitivity, careful evaluation of the retinal function. In the course of that study, we examined contrast sensitivity using the Peli-Robson, and this is a test that is designed to assess for the sensitivity to contrast, which means to light-dark transitions, being able to perceive images or patterns in a sort of dim or washed-out appearance. And what we discovered was intriguing and quite dramatic. We did not expect to find any abnormalities in patients who were otherwise healthy and had no other medical conditions, but in fact we did. We found significant differences through this eye safety testing protocol. We found significant differences in visual perception in the realm of contrast sensitivity between the patients and controls. And the differences were large enough to suggest it was not a random finding. So when we convert the data results from the clinical testing to Z-scores, there were Z-scores of 2 to 3, and they were very different when we looked at sort of age-matched, sex-matched controls. So we were concerned, oh, this is not a random finding. What does it mean? Certainly contrast sensitivity is not associated with circadian functioning. It doesn't really relate to that pathway that could explain light therapy responses, but it does relate to possible impairment in the neural visual network that processes visual information and photic information, allows patients to perceive and adapt to the visual environment. Contrast sensitivity is very important for driving, for reading, for day-to-day functioning. And our patients may have been suffering from impairments in this without our knowing. And in fact, when we went back and looked at the literature, again, from another group at the University of Pittsburgh, ophthalmologists actually had described this years ago and had reported on diminished perception of ambient light in patients who had clinical depression, and that the patients indeed reported an increased frequency of experiencing that the surroundings appeared unusually dim much more frequently than patients without depression. And it's by Dr. Feinberg and others from years ago. And we went to the literature and looked at the publications on unipolar depression. Also, intriguingly, around the same time we were doing our studies, others had started to publish reports. Interesting title, describing seeing gray when they're feeling blue, depression being measured in the eyes of the diseased. So, in fact, these are patients who did not have eye disease. They're actually having depression. And when they presented patients with visual stimuli in the form of checkerboards that were flipping back and forth really quickly, they were actually able to detect significant differences in visual responses at the level of the retina, differences between the controls who had this nice, or if you look at the middle panel, the B panel, sort of a nice upward movement of the line with the increased contrast versus the low sort of that low elevation in the patients who had depression. And you can sort of look at the electroretinography measures in the third panel to your right that sort of clearly defines the differences in electrical activity at the retina in the patients who had depression with or without medication treatment, and the patients who were controlled had significantly increased retinal electrical activity of the retina. So this is very different from what we were speculating with light and effects on the circadian rhythm. And we're just going to kind of move through this quickly. But okay. And what it prompted us to do is to sort of move forward this intriguing finding in our patients who had bipolar disorder and sort of really try to question what is the integrity of this visual cortical system that is not only receiving information that's, you know, the light input or the photons, but how exactly does the light sort of go on to affect the system that is regulating our mood and the depression brain circuits. But we wanted to sort of characterize, first of all, the visual cortical system before we go a little bit deeper. And by doing so, we wanted to build on the Pillay-Robson test scores and sort of take objective measures of contrast sensitivity, again, by measuring retinal electrical activity and electrical activity of the visual cortex with visual evoked potentials in patients who have bipolar depression compared to healthy controls, and to examine if there might be some changes before and after light therapy. So here's a diagram of a cartoon of the visual system. So from the right side, you can see how the eyeballs, the back of the eyeballs, where the retina is located, and it's followed by optic tracts, which then will relay information to the thalamus, which are sort of deeper brain areas, and from the thalamus will relay further information to the visual cortex and beyond. All right, so when we present light, or if we present visual information in the form of checkerboards that are flipping back and forth, eventually the information will reach the back of the eye, which is where the retina is located. And the retina is really this amazing system that is comprised of many layers of cells. And the layers of cells include the layers of cells that we're most interested in is we're interested in the photoreceptors, which process different colors, light, rod, and cones you've heard of. But particularly, we're interested in the retinal ganglion cells. These are the cells, actually, 3% of the cells contain a pigment called melanopsin, which is sort of the pigment that processes blue light that may be which is the sort of the wavelength of light that is integral to signaling the suprachiasmatic nuclei and regulating our circadian timing system. And so for that reason, we were very interested in retinal ganglion activity. And in fact, when we take measures of ERGs, we can gain a measurement, an objective measure of retinal ganglion activity. I'm sorry, I'll just keep going here. And pattern ERGs with the flipping checkerboards are really attuned to measuring retinal ganglion activity. In comparison, if we were to flash lights that, or flash different colors, we're going to activate different cells in the retina that include the rods and cones and the inner layer of the retina. But we're really interested in the ganglion cell layer. And there are specific components of the electrical ERG readings that we can examine carefully and look for changes that will relate back to the retinal ganglion cells. Need to just move on here. And the visual evoked potentials also can be measured by placing leads on the back of your head. So the ERGs are captured through almost like contact lens type leads. They're placed on the surface of the eyeball, which actually measure retinal activity at the back of the eyeball. Visual evoked potential are captured through electrical leads. They're placed on the back of the head, close to where the occipital cortex is. And again, they too will respond to various visual stimuli, including the flipping checkerboards. And there are specific components that can be measured from the output. And these are the 3 components listed here that can provide some indication of the integrity and functioning of the visual cortex before it sends off its messages and streams to the dorsal and ventral parts of the brain. So this is really what we're interested in doing. And with the help of NARSAD, we were able to get this project started, and we were able to start looking at what you can see here are the panel. The middle panel is really what we did most of our work with, the support from NARSAD, and also through NARSAD, and also with support from our university, develop not just the checkerboard protocol, but also build on that, understanding what are the effects of emotions on visual functioning. So we're first of all looking at the responses to in the early visual processing system to very neutral, non-emotional stimuli that involves sort of provoking the visual system with different levels of contrast, and finding that there are likely differences in the patients who have bipolar depression before they experience light therapy versus the controls. And so the light therapy patients provide, a whole range, but many of them actually have low levels of contrast sensitivity versus the patients who are controlled and more robust, sort of active responses in their visual cortex. We were not able to sort of get that pretty response from the retinal measures. However, that may have predicated on sort of differences in the rate of presentation of the checkerboard pattern. So we may adjust that to see if we can find a more sensitive measure using the retinography measure. But intriguingly, we may also detect differences in the visual responses to the checkerboards, which are pretty neutral, but also to emotional faces that can have an effect on regular visual processing responses. And so what we are now developing is building on this. We will seek to enhance our understanding of not only the visual system, but also how it interacts with the depression circuits before and after light therapy by sort of building on this early understanding of the visual responses using some of these measures to test early visual processing. And one of the things that we have started to do is actually sort of what is exactly happening if we use bright light as a little bit as a probe to assess contrast sensitivity. So here is my colleague at Carnegie Mellon University, Dr. Tyson Lee, with his student who's now graduated, working in Silicon Valley, I think. And together we developed an intriguing pilot study to look at bright light, implementing as a probe and assessing the visual responses before and after the exposure. And we're starting to find significant differences in controls that suggest that light exposure can impact quickly alerting effects and more sort of diffuse, not just localized visual cortical effects, but the light effects actually quickly can affect the central part of the brain and the frontal cortex, the frontal part of the brain that is important for regulation of mood and depression. So we are working together. We have now in the future, we are hoping to move forward with this protocol. We'll find out how funding, how reviewers will receive this this proposal, but clearly there are some promising effects that relate to bright light therapy in patients who have depression and patients with bipolar disorder that may or may not relate back to the circadian system, but can probably complement the effects of light on the circadian system. So this is, I think we're running out of time, but I wanted to make sure listeners understand that there are lots of resources out there on light therapy. One important resource I want folks to look at is to examine, test out the website, cet.org, the Center for Environmental Therapeutics, a wonderful resource for clinicians and also for patients, and also try to make sure everyone knows about our organization, which is the Society for Light Treatment Biological Rhythms. We will be hosting our annual meeting in 2019 in Chicago, so please check our website. We will be featuring more information on it. And also I include reading materials. There are some of the publications actually will be updated this year. The first one, Chronotherapeutics for Affective Disorders, a Clinician's Manual, is a wonderful resource for practitioners of light treatment and therapists who are interested in using light for treating mood disorders and regulating behaviors. Clinician's Guide to Using Light Therapy by Dr. Lamb and Tams, really one of the wonderful go-to clinician books. And on a more personal level, Experience of Chronotherapy, Resetting Your Inner Clock, written by clinician and also a patient writer who had some very intriguing experiences with chronotherapy. So I want to make sure everybody worked with has been acknowledged. I really appreciate all of the colleagues, assistants, statisticians, DSMB, so all of the friends and colleagues who help with the past studies and also with existing studies, supports from organizations like the Brain and Behavior Research Foundation, previously known as NARSED, from the National Institutes of Health and Mental Health, and small grant awards, all of which are very important to help support our group, and also donation of light boxes from the manufacturers. So just wanted to remember to say the date for our organization's meeting that will be upcoming next year. Thanks for your time, and if there is need for questions, I'd be happy to answer any, or can email me. Thanks.
Thank you, Dorothy, for the research that you're doing, and certainly an excellent presentation about the status of the field and the work that you're doing, which is so important. We don't have much time, but I'm going to ask you one question, a broad question, and ask for a quick response, which is, how does someone know if they or their loved one should consider light therapy? What would inform a person who has depression that maybe this is the right thing for them?
Oh, interesting. Yeah, that's a very good question. And I think what you're getting at is, what are some of the predictors of response to bright light therapy? And there are clinical predictors of response, and patients who have atypical symptoms of depression may be the patients, who have seasonal affective, who have perinatal depression, or who have bipolar depression. These are patients who struggle with problems with severe low energy, fatigue, hypersomnia, increased appetite, weight gain. These are the clinical features of atypical depression that can be very responsive to bright light therapy. But our group is actually interested in characterizing some of the biological effects, biological predictors, and we still don't really have good idea on what are the biological predictors for light therapy response. I think there's still research that needs to be done. We will be looking at it in our proposal that is being evaluated by NIMH soon, if they allow it. But I think that they're really important studies that can be designed to compare the effects of morning versus midday light, even using this light probe that we have started to test out at Carnegie Mellon, to see if there is an inkling of, to see if there's a sort of a quick assessment using electrophysiology, what we call EEG, to identify the most the patients who might be the most robust responders. Now, also going back to the circadian rhythm system, patients who have what we call circadian phase delay, who have more of the delayed sleep onset, they're going to bed after midnight, 2 or 3 in the morning, waking at midday. These are some patients who may be more robust responders to light, but if they have bipolar disorder, using morning light might be really risky, and so that is why midday light might be a sort of a more gentler but still potential produce a more gradual but a robust effect eventually. So the patients who do have the phase-delayed rhythms, patients have atypical symptoms, maybe the positive predictors of will gain the most response from bright light, and we're working on finding more objective markers with the research that we propose to do.
Well, that's very helpful information for people who are listening and are concerned. I'm going to again say to you, thank you so much for the work you're doing and for this presentation. And I want to thank everybody who joined us today. All of the research we fund is made possible through private donations, so please consider making a contribution by visiting our website, bbrfoundation.org, or call us at 1-800-829-8289. This webinar has been recorded. If you've missed any portion of the presentation or would like to share it with a family member or a friend, please visit the Events and Webinars page on our website. And I hope you'll join us again next month when Dr. Marina Picciotto, Deputy Director of the Kavli Institute for Neuroscience at the Yale University School of Medicine, will present Nicotine Receptors in the Brain, Implications for Addiction and Depression. This webinar will take place on Tuesday, October 9th at 2 p.m. Eastern Time. Thank you again for joining us, and enjoy the rest of your day. Take care.